Hello everyone, I am Anusha Grace DC. I'm here with the pathology topic thromboembolism. Firstly, thromboembolism is an obstruction of a blood vessel by a thrombus that has detached from its site of origin. It represents a major cause of cardiovascular morbidity and mortality. It commonly affects venous circulation, but sometimes it can also involve systemic arteries. Understanding its pathology is essential for its prevention and management. Let's define thrombosis. It is a pathologic clot formation within intact vessels during life. There are mainly three types of thrombi formed. Arterial thrombi, it is platelet rich and are called white thrombi. Venous thrombi, they are fibrin and RBC rich, hence they are called as red thrombi, whereas lines of Zahn, they indicate thrombus formation in the flowing blood. Now we'll see the major symptom and clinical presentation of thromboembolism. First, it is chest pain and then swelling. Coming to chest pain, there will be sudden onset of chest pain that may be with a sharp pain and potentially indicating a pulmonary embolism or thrombosis requiring immediate medical evaluation. Then comes swelling, which could be a localized swelling in an extremity, often accompanied by redness and warmth, suggesting the possibility of DVT and requiring prompt diagnostic imaging. Now we'll look what is Virchow's triad. This triad consists of three primary influences that is predisposing to thrombosis. First one, endothelial injury or dysfunction. Next, abnormal blood flow, also called as stasis or turbulence in blood flow. Thirdly, hypercoagulability of blood. First one is endothelial injury. This makes the important factor in arterial thrombosis. It is mainly caused by atherosclerosis, hypertension, smoking and inflammation. It leads to exposure of subendothelial collagen and tissue factor. This injury promotes platelet adhesion and activation of coagulation cascade. Next we have abnormal blood flow, also known as stasis. It is common in veins during prolonged immobilization or in heart failure. Turbulence is usually seen in aneurysms and atherosclerotic plaques. This disrupts laminar flow and prevents dilution of clotting factors. This also allows platelets to contact endothelium. And thirdly, we have hypercoagulability. It refers to increased tendency of blood to clot. There are inherited causes for this that could be factor V Leiden mutation, prothrombin mutation, deficiencies of protein C or S. Then acquired causes could be prolonged bed rest, cancer, pregnancy, and also oral contraceptives. This is commonly associated with venous thrombosis, likewise of stasis or turbulence. Now we'll see what is VTE, that is venous thromboembolism. This includes two main embolisms, that is DVT and PE, deep vein thrombosis. This commonly occurs in deep veins of lower limbs, that could be popliteal, femoral or iliac veins. Then these thrombi, they originate often in wall pockets due to stasis. Risk factors include surgery, trauma, malignancy and prolonged immobilization. Here we can see venous thromboembolism, where there is formation of thrombus, and next there is formation of an emboli or embolus in the vein. Now it also includes pulmonary embolism along with DVT. We'll see what pulmonary embolism is. Approximately 95% arise from DVT of lower extremities. This pulmonary embolism is a small emboli, maybe asymptomatic also. Medium emboli may cause pulmonary hemorrhage or infarction. Massive embolism can cause sudden death due to acute right heart failure. Now we'll see what is systemic or arterial embolism. It usually arises from cardiac mural thrombi during post-MI cases or arterial fibrillation. This arterial embolism may originate from ulcerated atherosclerotic plaques. Common sites, we can see them in lower limbs for 75% of the cases, sometimes in brain, kidneys and spleen also. This often lead to ischemic infarction. Now we will also see clinical features of pulmonary embolism. There will be sudden onset of dyspnea and tachypnea, including pleuritic chest pain and hemoptysis, tachycardia and hypoxia. And in case of massive pulmonary embolism, we can observe hypotension, syncope and sudden death. Now we will concentrate on symptoms and signs of thromboembolism. We have already seen chest pain and swelling. Now we'll see shortness of breath, where there will be unexplained difficulty in breathing, especially during physical activity. This might suggest a serious pulmonary embolism. Next is coughing blood. Coughing up blood or blood-streaked sputum is a critical sign indicating potential lung complications because of a clot. There will be rapid heart rate also, where an increase in heart rate can signal distress from a clot, especially with accompanying respiratory symptoms. Skin color changes can also be there, like pale or bluish coloration of the skin can indicate reduced blood flow, warranting immediate investigations. These are few signs and symptoms. Now we'll see common clinical risk factors for venous thromboembolism. Major risk factors and examples include people, men and women of age more than 70 years, then active cancer cases like ongoing chemotherapy, recurrent metastatic or any progressive diseases, major trauma, and in case of surgeries with general anesthesia given for more than 30 minutes and confined to bed for more than 3 days, and also in emergency cesarean section. These are major risk factors for DVT, and minor risk factors include surgery with local or regional anesthesia only, admission to hospital for less than 3 days. If more than 3 days, that will be a major risk factor. Now, estrogen or selective estrogen receptor modulator therapy. Examples will be OCP, hormone replacement therapy, or tamoxifen administration. Pregnancy or puerperium, obesity, and minor also could be long distance travel for more than 6 hours, also with first degree relative with VTE. Now we'll see generalized risk factors associated with thromboembolism. Firstly, as we read, immobility. Prolonged periods of immobility can cause increase in the risk significantly. Then recent surgeries, as it heightens the risk of developing thromboembolic events. Then coming to obesity, carrying excess weight contributes to the likelihood of thromboembolism. We have already read about cancer diagnosis and ongoing chemotherapy. Then hormonal therapies also can increase the incidence of thromboembolism. Chronic conditions like heart disease and diabetes can also raise chances of thromboembolism. As we're talking about thrombus embolus, we'll see how a blood clot is formed, the mechanism underlying the formation. It is generally occurring in 6 steps. We'll deal with them one by one. First is the vessel injury. This clot formation begins when a blood vessel is injured, exposing its underlying tissues to the bloodstream, which triggers the clotting cascade. Next comes platelet activation. Platelets adhere to the exposed collagen and they become activated. They release chemical signals that attract more platelets to the site of injury. This is followed by platelet aggregation. Activated platelets, they stick together, forming a temporary plug at the injury site, which is crucial for the initial stage of clot formation. So the third step forms the initial stage for clot formation. Now comes coagulation cascade. The coagulation cascade is initiated involving a series of biochemical reactions which lead to conversion of fibrinogen to fibrin. Fifth step is the mesh formation by fibrin. It is fibrin strands, they weave through the platelet plug, solidifying the clot and creating a mesh that stabilizes the plug and prevents further bleeding. And then there is last step, that is clot retraction. As the healing process progresses, the clot retracts, pulling the edges of the vessel closer together, which aids in tissue repair. So this is the mechanism of blood clot formation. We will also see about anticoagulants now, their types and their mechanism. Firstly, as we all know, warfarin is an anticoagulant. It is commonly prescribed anticoagulant to prevent thromboembolism. It requires regular monitoring for optimal dosing and also to decrease risk of bleeding complications. And then there are direct thrombin inhibitors, which are used for patients with heparin induced thrombocytopenia. These agents effectively inhibit thrombin, then reducing thrombus formation without requiring daily monitoring. Direct thrombin inhibitors do not require daily monitoring like warfarin. Factor Xa inhibitors. These agents offer predictable pharmacodynamics and do not require monitoring, allowing more flexible dosing and easy use in outpatient settings. These are more flexible. And lastly, there are antiplatelet agents. While primarily used to reduce arterial thrombosis, their careful combination with anticoagulants can enhance therapeutic outcomes and reduce risk of venous thromboembolism or also DVT. So that is why in treatment anticoagulation therapy is given. Initially unfractionated heparin or low molecular weight heparin is given. It is maintained by warfarin under monitoring. Also direct oral anticoagulants which need not have regular daily monitoring, and their duration, it depends on the cause and recurrence risk of the embolism. We can also give them thrombolytic therapy, which is indicated mostly in massive pulmonary embolism with hemodynamic instability. Agents used will be tissue plasminogen activator, that is TPA, but there is also one risk regarding thrombolytic therapy is that there could be severe bleeding complications further during or post therapy. Now coming to diagnosis, so D-dimer is used. D-dimer test, it is sensitive test but not specific screening test for venous embolism. There is compression Doppler ultrasound for DVT used, but the gold standard for thromboembolism is CT pulmonary angiography for PE and compression Doppler ultrasound for DVT. In some cases we can use ECG and ABG to support the diagnosis of pulmonary embolism along with CT pulmonary angiography. Now we are done with the diagnosis for thromboembolism. Now we will see what else could be used to treat thromboembolism. There are also two things, that is IVC filters, and we might opt surgical options. IVC filters, that is inferior vena cava filter, that prevents emboli reaching lungs. So that is its main purpose. IVC, it is used when anticoagulation or anticoagulation therapy or even thrombolytic therapy is contraindicated. Coming to surgical options like embolectomy, surgical embolectomy, it is only in selective life-threatening cases. We can consider surgical options as the last step, the last try for the treatment, only if the case is serious. So this was it. Now let us summarize thromboembolism quickly. First we got to know what thromboembolism is, where DVTs are more prevalent than PE in case of venous thromboembolism, but arterial thromboembolism are very rare. We defined it. Then there are three types of thrombi based on the location. Next we saw Virchow's triad, very important to remember: endothelial injury, or else dysfunction, abnormal blood flow, then hypercoagulability. It is important to know VTE consisting of DVT and pulmonary embolism. Pulmonary embolism follows DVT. Then signs and symptoms of thromboembolism. 6 signs and symptoms: chest pain, shortness of breath, swelling in limb, coughing blood, rapid heart rate, skin color changes. Next, we dealt with major risk factors, minor risk factors of venous thromboembolism. Risk factors mainly include immobility, recent surgery, obesity, cancer diagnosis, hormonal therapy, and chronic suffering conditions. And now then we understood how a blood clot is formed. Then anticoagulants used for anticoagulant therapy, that could be warfarin with monitoring, direct thrombin inhibitors and factor 10A inhibitors without daily monitoring, and sometimes antiplatelet agents in combination with anticoagulants. So this was anticoagulation therapy. Then there is also thrombolytic therapy, especially for massive pulmonary embolism with hemodynamic instability. Diagnosis, mainly it is D-dimer test, which is sensitive but not specific screening test. It is a screening test, not a diagnostic confirmatory test. Then gold standard for PE is CT pulmonary angiography, sometimes ECG and ABG. For DVT, it is compression Doppler ultrasound. Some life-threatening cases, we can choose surgical options or even IVC filters. That is only to prevent emboli from reaching lungs. So that is how we have summarized a life-threatening vascular disorder, thromboembolism. Pathogenesis, we explained it by Virchow's triad, early diagnosis, and anticoagulation therapy or thrombolytic. They are life-saving. And prevention plays a crucial role because in high-risk individuals, prevention is always better than treatment. So this was thromboembolism. Thank you everyone.